I am Dr. Nasmani, and in this video presentation, which is the third part of the ECG analysis of pediatric patients, I am continuing from what I stopped with the second one. The first ECG I am showing today is the electrocardiogram of a normal child, not the relatively tall R wave and inversion of the T wave in V4R and V1, that is shown by the arrows. And this ECG is the normal adult ECG, not the dominant S wave in lead V1. This pattern in an infant would indicate the presence of left ventricular hypertrophy, and I am showing the S wave in V1 by the arrow. And this pattern in infant means left ventricular hypertrophy, because as you know, during the infancy it is the right ventricle which is predominant in the first few weeks of life. Process of right ventricular thinning and the left ventricular growth are best reflected in the QRST pattern over the right precordial leads. The diagnosis of right or left ventricular hypertrophy in a pediatric patient can be made only with an understanding of the normal developmental physiology of these chambers at various ages until adulthood is reached. As the left ventricle becomes dominant, the ECG evolves to the characteristic pattern of older children and adults. Ventricular hypertrophy may result in increased voltage in the R and S wave in the chest lead. The height of these deflections is governed by the proximity of the specific electrode to the surface of the heart, by the sequence of electrical activation through the ventricles, which can result in variable degree of cancellation of forces, and by hypertrophy of the myocardium. So the height is governed by proximity, sequence and hypertrophy. Proximity of the lead to the heart, sequence of activation and hypertrophy of the myocardium. Because the chest wall in infants and children as well as in adolescents may be relatively thin, diagnosis of ventricular hypertrophy should not be based on voltage changes alone. Diagnosis of pathologic right ventricular hypertrophy is difficult in the first week of life because physiologic right ventricular hypertrophy is a normal finding. Serial tracings are often necessary to determine whether marked right axis deviation and potentially abnormal right precordial forces or T waves or both will persist beyond the neonatal period. In contrast, an adult ECG pattern seen in a neonate suggests left ventricular hypertrophy. The exception is a premature infant who may display a more adult pattern of ECG, what's called a mature pattern, than a full-term infant as a result of lower pulmonary vascular resistance in the premature baby, which is secondary to the underdevelopment of the medial muscular layer of the pulmonary arterioles. Some premature infants display a pattern of generalized low voltage across the precordium. So diagnosis of right ventricular hypertrophy in the first week is difficult. So series of tracings are needed. The ECG of an infant with the right ventricular hypertrophy is shown here. This is a case of tetralogy of Fallot. Note the tall R wave in the right precordium and the deep S wave in V6 and the positive T wave in V4R and V1 are also characteristic of the right ventricular hypertrophy, and that is shown by the arrow marks. You can see the tall R waves, positive T waves and deep S waves. Electrocardiogram of a premature infant is shown here, which was having a weight of 2 kg and at the age of 5 weeks of delivery. After the delivery, the cardiovascular system was clinically normal in this child, and the left ventricular dominance is manifested by the R wave progression across the chest, similar to tracings obtained from older children, compared with the tracing from a normal full-term infant below. So with these two ECGs comparing, you can understand what was told earlier. Now the ECG should always be evaluated systematically to avoid the possibility of overlooking a minor but important abnormality. One approach is to begin with an assessment of rate and rhythm, followed by calculation of the mean frontal plane QRS axis, measurement of segment intervals, assessment of voltages, and finally assessment of Tnt wave abnormality. The rate and rhythm. A brief rhythm strip should be examined to assess whether a P wave always precedes each QRS complex. The P wave axis should then be estimated as an indicator of whether the rhythm is originating from the sinus node or not. If the atria are situated normally in the chest, the P wave should be upright in lead 1 and AVF and inverted in lead AVR. With atrial inversion, that is situs inversus, the P wave may be inverted in lead 1. Inverted P wave in lead 2 and AVF are seen in low atrial, nodal or junctional rhythm. The absence of P wave indicates a rhythm originating more distally in the conduction system. In this case, morphologic features of QRS complex are important. That is, if the rhythm is originating distally in the conducting system, the morphology of the QRS are important in differentiating a junctional rhythm, which is usually having a narrow QRS complex, from a ventricular rhythm, that is usually having a wide QRS complex. In this panel I am showing some characteristics of the P wave. Tall P wave, that is more than 2.5 millimeter, and a spiked P waves. Tall, narrow and spiked P waves are indicative of right atrial enlargement and are seen in congenital pulmonary stenosis, Epstein's anomaly of the tricuspid valve, tricuspid atresia, sometimes in cor pulmonale. These abnormal waves are most obvious in lead 2, V3R and V1. Similar waves are sometimes seen in thyrotoxicosis, but this thyrotoxicosis is not that common in children. It may be seen in adolescents who have got Hashimoto's disease. Peaked narrow P waves, characteristic of right atrial enlargement, is shown in the picture on your right side. So that was the brief presentation on the tutorial on ECG reading. Thank you for sparing the time. Please visit my site www.youtube.com/ACEPGMed and please give me your feedback. Thank you.